links at the end of the presentation for some of those other pieces. I have a question in here: how will the newer medical home or global payment systems affect all of this? As we're slowly but surely moving away from fee-for-service and toward the medical home or global payment for the overall care of a patient, that's the big question. I can only assume as we move in that direction, the ground rules on charting are going to be the same, but how we get paid is not necessarily per service, but how well do we keep the patient and how little do they need to have extra testing or be in the office, and our chart notes are what are going to be the proof in the pudding there. So we need to have good chart notes, especially as we move to this more and more evidence-based global payment system. When and how that's going to exactly move forward is anyone's guess at this point. The overarching principle in billing and charting is do what is medically necessary. Completely document what you do, and then accurately code what you document. Simply put, everything is supposed to match up. Whatever codes the insurance company gets sent from your office on a HCFA form or a CMS 1500 should match what you did in your chart note. And that is what we're going to explore this evening. The big question, however, is how are you supposed to do all of this in a timely manner and still make sure that you're getting paid for your good patient care? As we move through this evening, I'm hoping it'll become very clear that many of us are doing 99214 and 99204 level of work with our patients, but whether or not your chart notes actually show that is a different issue. So that's what we want to make sure, that we are documenting everything so that we can make sure we get paid accordingly. So if you understand the overarching principles in charting, and you learn the basic required elements for the most used CPT codes in our practices, then with some practice, you apply that to your patient care process, create the right charting templates, and then those help work for you in facilitating the rules of insurance charting and billing, but yet you can still do what you do as a doctor. Whether you're on paper charts or you're in EHR and electronic medical records, either way, you want to create templates to facilitate your work, knowing that templates can also be a double-edged sword. If every chart note looks exactly the same, because especially with EHR, this is a problem, you can very easily just click, 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 and just fill in or cut and paste from an old chart note into a new chart note. They're going to notice that when they audit a chart, and it's not going to fly. They will probably down code every one of those visits because it doesn't look legitimate. A little bit of a problem with electronic charting because it's, you asked all these ROS or review of systems questions. Sometimes they are going to look pretty familiar, but you just need to be aware of doing the same thing over and over again. That's also a flag. So as far as the guidelines and how the guidelines are written, it's quite an intelligent system as far as process and as far as creating an algorithm to follow so that you don't miss any diagnoses and you quantify your brain power that you had to use in this patient encounter to arrive at a chosen diagnosis and then the subsequent treatment plan. It works really, really well from that standpoint. What is not necessarily happening, though, is how well the ease of use, how easy it is to interpret, how easy it is to follow the guidelines in individual patient